So you will be presenting it. Okay, so I request Professor Sanjeev Bhoi, so he looks after the emergency center of AIIMS, to come and deliver presentation.
Casualty. वहाँ फोन कर दो. Okay. So thank you, sir, and this topic is called as e-presence without being present. The genesis of this presentation is, it started few years back, some 6-7 years back. I am being an emergency physician. I worked in the emergency. The sad part of this is, in the journey of casualty to emergency medicine, nobody wants to join actually emergency medicine or the so-called casualty, because a new discipline, and very less people you will find to take up this as an academic department. And similarly, when we started new at AIIMS, I am being a medicine faculty, joined emergency medicine, and took up it as a challenge to try to traverse the journey from casualty to emergency medicine. So alone faculty, however, there are many posts to advertise and nobody joined. With a limited resource, I had to be present, omnipresent all the time in the emergency department. It is very difficult working, from morning 8 o'clock to evening 6, 7, 8, every day for the last 6-7 years. Initial years from 2004 to till last 2 years. Now I have one more faculty with me. So it became really pretty difficult, to man the emergency round the clock. And to provide quality of care, you require the consultant present, to making quick decision, and that is where we lack. It is the area where if you have slight sneezing to cardiac arrest, emergency related to neonate to prostate, they all come to the emergency. And when such sick patients come to the emergency, this is the last area where we don't give any importance to it. We put all the junior most doctor working there, who was working for their postgraduate exams, and they didn't have that kind of training to deal with such sickest patients, with complex of patients. And we leave the initial, we talk about the golden hour concept. Oh my God, give me a break. So that we try to develop that over last decade at AIIMS. Still there are many challenges. Obviously the faculty cover was key to implementation that. So I worked with my resident, with my nurses. It was made a nurse-driven system at the trauma center emergency department. So all the processes, protocols were made and put into practice in the trauma ER. Just like a McDonald's, you go, it is same across the world. Pizzas, same across the world. Similarly, protocol and process are put into place, but it required quality improvement, it required continuous monitoring. So after 6 o'clock, how to take care of those issues? Yes, it is what they say is easy to build a system, but maintaining a system is a huge challenge, and that is where we lose out in our country. So let's see how this is just right off the different way of thinking, that I thought that why not to be present without being present in the ER. Even if they see my face when I'm taking a round in off hours, maybe late in night, if I'm taking a round, at least my resident and nurses will be geared up, alert to at least, yes, my boss is with me, and giving critical decisions and off time. So I used one of the platforms. A disclaimer is with no conflict of interest. I used Skype that time with able support from Dr. Deepak Agarwal. So initially we started with some simple dressing trolley. With a small trolley, we had to bought a notebook, and we started connecting with Skype. Let's see whether we can take a Skype round on that. So I'll just call upon, I think, to the casualty. and this we have been doing since last few years. Obviously, there are issues and challenges and questions about it. Yes, Shakuntala? Yeah, can you give me a call from there? Good morning, Shakuntala. You are live now. She is Shakuntala. She is our ER nurse, and she is going to give a round of the red area. Can you just call up on my mobile so your thing can be, heard, your voice can be heard from there when you present. Yes, go on. Go on. You can call me on my mobile because audio is a problem. What we do is we try to connect through our mobile. Okay, go to the red area, please. Okay, that's Tej, and can you just connect this one, to this, live to this thing. Okay, Tej, that is Dr. Tej Prakash, our assistant professor in emergency medicine in the red area. Can we go to the patient, to the bed number 1 and see from a distance? Can you just describe from there? Just put the screen a bit, hold it down.
Right now we are having only one patient in our red area.
Okay.
Who is already being evaluated. So
Okay.
with me our senior resident Dr. Vishnu is here.
Okay.
Along with our nursing colleagues and senior resident Dr. Abhijit. So Dr. Vishnu will be telling you in detail about this patient.
Okay, Vishnu, yes. Hi, hello Vishnu, yes. Tell me about the patient.
Okay, sir, this is a 40-year-old male patient who had a history of road traffic accident, two-wheeler vs four-wheeler. Patient was brought to emergency yesterday, and he was diagnosed with a cervical spine injury and also suspected swelling in the neck. On evaluation, we found that there is a subcutaneous edema and there is a moral level lesion, deglowing injury in the aspect of neck.
And what are the ABCs of this patient?
Sir, airway breathing and circulation was fine. Initially, he was in shock. Patient was resuscitated and he was started on NORAD. Now the NORAD has been tapered off. Patient is now hemodynamically stable. The GCS is full. GCS score is full.
Okay, what are the injuries identified?
Injuries identified is spinous process fracture of C6, C7 and D1 and blunt trauma neck.
Okay, blunt trauma neck. So what is the plan of this patient? What we are doing on this patient?
To admit the patient under surgery. Surgery has already advised admission, but we are waiting for beds for this patient.
Okay. Sir, okay, Vishnu. Yeah, we can just move the trolley towards the yellow area, Tej. A little bit on towards the yellow area. So this is the red area we have. So you can see all the bays there, and generally you can do bed to bedside, round like this, and ask detailed questioning. Then you can also have a feel, the critical treatment decision, what needs to be done about the patient, that can be done. So this is our bed number 1 actually with the trauma resus bay. You can hold on there.
Yes.
Yeah, hold on there.
Yes.
So you can see this is
the
red resuscitation bay. We have bay number 1 in the emergency room, and where actually you can do virtual resuscitation as well. So that is what it is when off hours, so you can take a round, clinical round, administrative round, and give the real-time decision making or remote decision making, which can be a big help on the patient. So thank you, Tej, for connecting with us. Thank you, all of you. Yeah, we're finished.
So thank you, Dr. Bhoi. Any questions?
Thank you.
From the audience or any clarification you want?
So this is, we are doing it very regularly. Just to briefly summarize, if you have any question, I'll take, otherwise just summarize. So if not, let me just summarize for you that we have been doing this for last 6-7 years. Now in our emergency RODA, if the consultants anyway in the emergency should be around the clock, but we don't have that much of faculty. We have only 2 faculty. So to giving a provider cover every evening at 9 p.m. You know, one of the faculty who is on shift that day, sir, he takes a Skype round, you know, every day. So at least we make some, you know, make a difference on attending.
It's good beginning, Dr. Bhoi, and some suggestions. Actually, what is lacking is here you cannot transmit with the current system a lot of investigational facilities. So if you have a PACS connected to here, then you can see the PACS and see. Otherwise, with the conventional thing, you can project to the camera to the screen and take some X-rays, because the first person you saw the trauma case.
Yes,
so naturally, you need the investigations. So, so maybe we have got a very good network here. So maybe you can build up that network. External examples. Second suggestion is, so what happens actually, you are moving the trolley from one place to another. If it is just only video-based consultation and review, then you can think of head-mounted cameras. Now the head-mounted cameras are available. That becomes very versatile. So you do not have to take the trolley.
With the physician wearing
just nowadays you get very good cameras, very high definition cameras.
Okay,
so you can directly stream from there using the Wi-Fi network.
That's a good suggestion.
So build Wi-Fi in the now Wi-Fi is quite safe.
Wi-Fi we have a good zone.
So just there are Wi-Fi cameras available. So head-mounted cameras directly you can stream from there.
Okay.
Third thing is you can integrate some of those nowadays wireless devices. We can integrate to your network. Only thing now you have started with a conventional taking the Skype and all those things.
Yes,
but you can build up a customized thing for your requirement.
Okay,
and very good examples are available.
Yeah.
You can. There are must be vendors also to do it actually.
Okay, sir.
So with that, thanks. A very good initiative.